Good afternoon, everyone, or morning, depending on your time zone. Welcome to the October 2023 Quarterly Arkansas All-Payer Claims Database, APCD, Data Users Group. That's our 17th Users Group session. For those of you who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, the ACHI, and is administered by the Arkansas Center for Health Improvement, or ACHI. The Arkansas APCD is comprised of private carrier and public payer, medical, pharmacy, and dental claims, as well as enrollment and provider data. Additionally, the HTI enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, hospital discharge data, and emergency department data for those who are self-pay or uninsured, cancer registry data, and some medical marijuana card holder data. We also have some Arkansas workers' compensation data. We hope you find today's session helpful. Some housekeeping before we move forward. Feel free to type questions in the chat at any time and we'll address them as we can. Our project manager, Jennifer Medley, is on. And Jennifer, if you see a question in the chat, be sure to jump in and let me know if I don't see it. At the end of today's session, we'll provide a link to our service desk application where you can enter any question or topic you're interested in discussing. The Arkansas APCD data can be complicated. You can also request time with our team to address specific questions you may have about how to use the data, or the type of information that's within the data. The link to this deck will be provided in a follow-up email that you'll receive this afternoon or in the morning. It will have a recording. It'll have a link to the deck proper and a recording of today's session. And finally, our next Data Users Group session is scheduled for January 24th, 2024. Can you believe it? So let's go to the next slide. I'm going to take myself off camera. Is everybody able to see the agenda? Jennifer, will you let me know? Okay.
Yes, we can see it. Yeah.
Thank you. Thank you. All right, our topics today, we have a featured project, Arkansas Dental Care Utilization Analysis, presented by Sarah Crawford. We are going to have an Arkansas Claims Versioning recap, using member enrollment flags, and then the latest APCD release information and data tips. Let us move forward. I'm Kenley Money, Director of Information Systems Architecture and the APCD Director of ACHI. And we are going to hear from Sarah Crawford, Senior Data Analyst at ACHI. So Sarah, I'm going to stop sharing and you should be able to share. Let me know if you have any trouble. There we go.
Okay, do you see it?
Uh-huh.
Okay, good. So hi, I'm Sarah Crawford. I am a Senior Data Analyst here at ACHI. I've been here about 3 years, and I'm presenting on this dental project that we did probably about a year ago. So this report was funded by Delta Dental of Arkansas Foundation, and it supports improved dental care utilization and oral health in Arkansas. We used the APCD to produce the information in this report, and it was released in June of last year. You can access the full report from our oral health landing page, and that is listed there. I would encourage you to visit there, as there's a lot of information covered that I won't be able to get to. So the goal of this analysis was to profile baseline levels of dental care utilization and related measures. We used 2019 as the baseline year for most of our metrics, both because it was the last pre-COVID year, and also because when we first started the project, that was the most recent data available. We also included 2020 experience for some of our trend analyses, and to have a look at the impact of COVID. Some of the key measures that we looked at included dental coverage profiles by county, pandemic era utilization trends for 2019 versus 2020, utilization of preventive dental visits and other service types, utilization of dental care and other non-dental medical settings, active providers per county and ratio to population, fluoride varnish application trends, and utilization of dental services among uninsured individuals within emergency medical settings. I'd like to share with you some of our key findings before getting into the details. In 2019, 54% of Arkansas residents had evidence of dental coverage in the APCD. That was 1.6 million individuals. We found that too few individuals seek preventive dental care even when they do have dental insurance. COVID-19 dramatically impacted utilization in the state, but utilization mostly returned to pre-COVID baselines by the end of the summer in 2020. Some counties have a patient to active dentist ratio that's higher than the health provider shortage area thresholds, meaning they do not have enough dentists servicing the area. Individuals with private dental coverage utilized preventive services at a higher rate than adults on traditional Medicaid. Many individuals seek dental care in medical settings, including emergency departments. Utilization was generally lower among individuals who had preventive care at a dental office in the previous year. Many individuals with no insurance sought dental care in ED settings, associated with annual charges totaling about $6 million. That's for 1 year. Let's see, more key findings. Fluoride varnish applications, both by dental and medical providers, have generally increased annually since 2013. And also analysis of opioid prescribing for tooth extractions found providers generally followed the guidelines, with 3 to 4 days supply being prescribed on average. So this is showing the estimated proportion of Arkansas residents that were represented with dental coverage in the APCD at some point in 2019. We found that we can see that dental coverage, most children in the state had dental coverage, and about half of adults in the state, we can find evidence of the coverage. And that proportion of covered adults generally declines with age. There are going to be people who don't have dental coverage that we cannot see, or that do have dental coverage that we cannot see, and also other people who have different like non-insurance-based dental discount plans that we wouldn't be able to see in the APCD as well. So those are not included in these numbers. This map shows the percentage of individuals in each county that had evidence of coverage as seen in the APCD in 2019. This is using the 2019 Census ACS Arkansas population estimates as the denominator for each county. This map shows the proportion of those with dental coverage in the APCD that used any type of dental services provided in a dental non-medical facility in that year, in 2019. So this would be like not in an emergency room or urgent care, just in the dentist office. This is across all ages and coverage types. And you can see that the counties with the highest proportions receiving dental care were in the center, more populated part of the state, and in the southwest counties. The county with the highest proportion was Sevier County at 45.1% of individuals using any dental services. This would include routine dental visits, and this is a number that we would like to see increase across the state. This is a breakdown of how we grouped dental procedures in our analysis. Diagnostic included things like evaluations and imaging. They would often happen along with preventive procedures, things like teeth cleanings. Restorative included things like fillings and crowns. Endodontics included root canals and things like that. And then periodontics includes dental implants and gum issues. So we looked at utilization of any services in any of those procedure groups by rural versus urban counties. As you might expect, we found that the use of preventive and diagnostic services were higher in urban counties. And this may have to do, at least in part, with having access to providers. And we're going to show a little bit of data on that in a little bit. The other services can be more acute, and you can see that the rates are much more similar between urban and rural counties for those restorative, endodontics, and periodontal procedures. So this slide shows a comparison of the proportion of covered individuals who use dental services in 2019 versus 2020. In March 2020, in response to the onset of COVID-19, the Arkansas Department of Health mandated a pause on dental services. Services were allowed to resume later that spring, but the pause and probably some people's reluctance to visit the dentist even after they did reopen, unless it was acutely necessary, did appear to contribute to an overall reduction in the proportion of those who received dental care in that year. Related to that, this is a monthly utilization trend comparison for all dental services in a dental setting between 2019 in blue and 2020 in red. You can see that dip in the second quarter of 2020 where it drops dramatically starting in March into an April low and then starting back up in May to be back close to 2019 levels in June. The blue line, the blue line's 2019 and the red line's 2020. So let's see, this slide shows dental care use by age groups for preventive services only. For those in our line of sight with dental coverage. We see the best rates in the 5 to 14 age groups, but even there, they aren't that far over half. The 0 to 4 age group appears to be an area of opportunity, as well as the 15 to 19 age group. Once they hit adulthood, young adults in their 20s see a big drop in seeking preventive services, and then again, these rates are among those who do have dental coverage, but many just aren't using it for those preventive services. So this is the same age groups, but this one shows the proportion of the insured population that received any service in the dental setting in 2019. So you can see increases across the board, but in kids 0 to 19, there's about a 4% increase over those seen just for preventive care. But that jumps to 7% of an increase for 20 to 24 age group. And then it's about 10% above the percent of seeking preventive care through the rest of adulthood. So we know that too many patients seek dental care in emergency departments. We identified individuals with dental coverage who sought care in emergency departments and then looked back 12 months prior to the date of the ED visit to determine how many of those patients actually had any preventive dental visits in that 12-month period. For kids, we found that the slight majority, 51.4%, did not have a preventive visit in the previous 12 months. However, among those with private Medicaid or Medicare Advantage coverage, the vast majority had no evidence of preventive visits in the 12 months prior to the ED visits. So this really underscores the importance of having those routine visits to avoid downstream bad outcomes. And again, this is people that did have the dental coverage. They just didn't seek the service. We also looked at ED use for dental services among the uninsured and found that nearly 4,000 ED visits in 2019 for dental care among the population, the uninsured population. Associated charges for those visits were almost $6 million, which translates to a significant amount of potentially uncompensated care for hospitals. This map displays an average charged amount by county for a dental-related ED visit among the uninsured. Switching gears to look at dentist availability and access in the state. There are a lot of different ways that this can be looked at, but we assessed the number of dentists in each county who served at least 20 individual patients in that county in a year. So this is looking at the address of the service. We set that threshold just as a pretty minimal number. 20 individuals isn't really meant to represent a typical full-time patient load, which would typically be much larger than that. But we found that in Cleveland and Lafayette County, no dentist served at least 20 patients in those counties. And you can see them here in red. Many other counties had more than 5,000 residents per quote unquote active dentist by this definition, which that is the threshold for a dental provider shortage area as designated by HPSA. As you know, there are plans for the dental school coming to Little Rock, and we hope that this will increase the number of dentists practicing in the state, specifically some of these low access areas. We also looked at the proportion of active dentists who saw any children with Arkansas Kids coverage. These are children on Medicaid, all of which receive dental coverage, and all of which we have line of sight on. We found that statewide, only 61% of dentists saw at least one of these patients. Acceptance of this coverage type appears to be lower in some of the urban areas of the state compared to rural areas, possibly because their business is able to be sustainable without their inclusion in those areas. Some of these counties with the high percentages only have 1 or 2 dentists that service the county at all. So if that dentist saw a kid with Arkansas Kids, then that county might show up here as having a high rate of acceptance. We looked at fluoride varnish utilization, and it has generally increased since 2014, with the exception of 2020, when overall utilization was down. The black line here, which is the one on top, is overall utilization. And then the other lines represent the 2 main codes used by dentists to bill for varnish applications. We also looked at those varnish applications in medical settings. Legislation was passed in 2014 to enable medical providers to apply fluoride varnish to children's teeth. This is something that the Office of Oral Health in ADH has encouraged and supported, and we do see varnish applications in medical settings increasing. The black line is the overall utilization, and the other lines represent the main codes that are used to bill for varnish. You can see that the D1206 code in red is trying to be phased out, with the preference being to use Z293 or 99188 to bill for these. And we also assessed the number of varnish applications per child within a year. The current recommendations are that kids receive 4 or 5 applications a year. However, that's not what seems to be realistic based on what we found in the data. This is part of why we're trying to get this to also happen in pediatricians' offices to get those numbers up per kid. We do see 2 out of 3 covered kids with at least 1 varnish application in 2019, with 41% having only 1 and 25% having 2 applications in the year. Okay, just before I wrap this up, this slide shows the number of medical providers who submitted claims for at least 20 fluoride varnish applications by specialty type. We see a lot of pediatrics, as you might expect. Arkansas Children's Hospital is one of the larger groups among them. Overall, there were 324 individual medical providers, physicians, or nurses, or practices that performed any fluoride varnish applications. There are a few areas in which we plan to continue our research in this space. We'd like to pursue more in-depth research on provider availability and access, linkage of data, or linkage of additional social determinants data, further linkage with medical claims to assess impact of dental care and oral health on overall health, and analyses of reimbursement, benefit limits, and costs by coverage type and potential impact on providers and patients that those have. So ongoing collaborative patient education efforts are needed to reinforce the value of routine dental visits. And future analyses could be strengthened if additional data sources were made available, such as private self-insured employer claims, public health dental services, temporary or pop-up dental clinics, or information from other non-claims-based dental care. But it's been a pleasure to share this with you, and I'm happy to take any questions if you have any. Otherwise, I'll send it back to Kinley.
Thank you, Sarah. That was terrific. That was terrific. Anybody have questions at this time? Well, feel free to put a question in the chat and Sarah can address it later. Or reach out to us after the session. All right, now I'm going to reshare. Where's my okay. All right, everyone should see my slide APCD claims versioning recap. Yes. I chose this subject because, thank you, because in the past 6 to 8 weeks, I've gotten a couple of questions from data users about versioning, and I thought, well, what an opportunity to recap it and redefine it for those of you who may not be familiar or haven't used the data enough to know what we're talking about. So let's do a quick recap on what claims versioning is. So changes can occur to medical, pharmacy, and or dental claims after they've been delivered to the Arkansas APCD. In short, if you go to the doctor and a claim is filed and it changes for some reason, you argue it or they make a change to a price, whatever, a change step occurs at the carrier, at the health insurance carrier, and to alter the code or the date or the dollars, and that's what you're billed ultimately. Well, that will generate a change that ultimately comes to us so that our data is in sync with what's at the carrier. So they can occur to all types of claims, and some call it adjudication. We have a term, and it's a common APCD term called versioning. These changes or versions are received in later submissions to the APCD. Each submitting entity has its own rules to integrate changes with existing claims data, resulting in a final version of a claim. This is claims versioning. Yes, you would think that there would be a common way for changes to be made to claims, but that is not the case. Overall, only about 10% of the claims require versioning. Changes occur, but it's not a lot. But still, it's important to know how it's done. And yes, there are some carriers that don't version at all. We'll talk about that. So let's see, what does it look like? Well, first I'll say we have a document on our website that outlines the versioning methodologies. More detailed claims versioning information is included in our data submission guide. And this is the guide that the submitters, the carriers, are required to use to build their data they send to us. Let me say, we are going to do the versioning for you. So you shouldn't, except with just a couple of carriers, you shouldn't have to worry about this at all. But it's important to understand how it works and what it will look like ultimately in the data that you receive. So we have 15 or 20 different versioning algorithms, and they were all designed by the submitting entities. So when we started getting data back in 2015-16, and we had to implement versioning, we worked with each and every carrier and said, how do you update your claims? So that the data, the processes that we use ensured that our claims were updated the same way they update their claims. So in this particular one, and each approach had a number. Approach number 1. So originally we got these 3 claims, and this is one claim number, and there are 3 lines. Whatever happened, there were 3 procedures for this one service, and the total was $60. And then in a later submission, we got a back out. And so for claim line 1, so that really meant the only 2 active ones were these 2. And then We got another adjustment. So claim line 2 had an adjustment and claim line 1 was replaced. So ultimately, this whole claim was worth $50 altogether. Now, you as a data receiver, you're not going to see all this. What you will see is this claim line 1, because it's the last one, this claim line 2, because it's the last one, and this claim line 3, because it's the last one, but nothing ever happened to it, so it's the first one. So you won't have to worry about all of this noise that happens in the middle. Let's look at another one. So there are different ways to identify how to version. I'm going back. So in this case, there's some numbers here, claim version numbers, and sometimes it's a date instead of a number. And the principle here is the same. We have an original submission. This particular carrier doesn't have claim status, and that happens. And claim line 1 was changed twice. And so you're going to get the latest one, and you won't have to worry about the rest. Pharmacy claims, it's very similar, very well, it's very similar and pretty cut and dry. Sometimes they have different claim numbers, and so we group on something else. We'll group on the member, the fill date, the prescription number, the fill number, and we'll be able to build our picture of the claim lines to keep based on that. It is not uncommon for pharmacy carriers to have different claim numbers on all lines that have to do with a fill. So sometimes you will see this. Again, you won't have to worry about that. We'll give you the last one. So my point is, don't be afraid. Versioning is a point in time. And if you have a data set right now, then it's possible that in 6 months, when we refresh our data, what's in your set will change, but it doesn't change often at all. And our data is fairly mature anyway, because the data available right now, this is October of 2023, was through March of 2023. So there's been a lot of time for for it to mature and stabilize. A claim can be versioned more than once in multiple updates. Data requesters, you receive the latest version of the claim record, not the older ones. Duplicate claim lines and claim lines with invalid data are not included in the data provided to you. So sometimes a row is duplicated entirely, you don't get that. Sometimes the data in it is invalid or ambiguous, you don't get that. But some, like I said earlier, some submitters don't version their claims. They can't version their claims. And so there are data tips that will tell you how to deal with that. And we'll make certain that the data tip includes which carriers don't version their claims. There's a field on your claim line 706. Actually, I'm going to share a different screen real fast. Stand by. Let me find it. Screen 2. This is screen 3. Yeah. All right. So a couple of slides back, I said there's a document on our website and there was a link to it. And that link takes you to this document. And this document talks about all of the versioning approaches and how to find out where to look in your claim about which versioning approach it is. Again, this is just supporting documentation. The claims are versioned by and large. If for some reason, I will point out approach 8, if the value 8 is in one of these fields, MC 706 for medical, PC 706 for pharmacy, DC 706 for dental, then there are no versioning rules. And that's one of those carriers that doesn't know how to version, or they don't need to version their claims. Just something for you to be aware of. If you get in your analyses that you have some of these unversioned claims, do not hesitate to reach out to us and we can help you through it. We can. All right, let me go back to my, okay. I've been looking forward to this because these three fields, ME 018, 19, and 20, are they can seem like they're a conundrum using member enrollment flags. So let's take a look. Sometimes, well, as you do your work, you will find that there are members in the enrollment data that do not have claims. They don't have any claims, and that is perfectly logical, that you could have health insurance and not use it. Sarah described it with dental insurance. There are people with dental insurance and they're not using it.
Kinley?
Did someone say something? I'm sorry.
Yes, we're not seeing a share.
Oh, there we go. How about now?
There we go.
Thank you. Thank you, Jenny. So as I said, and Sarah described it in her presentation about the dental claims. Well, there are three fields on the enrollment data, ME 018, ME 019, and ME 020, that indicate what type of coverage the member has. So let's look at ME 018, medical services indicator. If the value in this field is 1, then this member has medical coverage with this submittal. And you can see the other values: 2, no, 3, and none, 4, other, 5, not applicable. By and large, the values are 1, 2, and 3. ME 019 behaves the same way, except that it indicates pharmacy coverage, and ME 020 dental coverage. So if the value 1 is found in these fields, that means that type of coverage is provided for that member. Claims processing systems are sometimes managed in silos. Medical claims processing systems are often separate from pharmacy claims processing and dental claims processing. This occurs naturally when plans are managed by TPAs and PBMs. So if your medical coverage is handled by United, but your pharmacy coverage is managed by a pharmacy benefit manager such as CVS Caremark, then United won't know, doesn't always know that you have pharmacy coverage, and certainly the PBM won't know if you have medical coverage. So you have to use these fields creatively to get to your answer. So let's pop down to these examples. For example, to select members with medical and pharmacy coverage, using this select statement will not catch all qualifying members. Select star, whatever, from whatever table you have, where ME 018 equals 1 and ME 019 equals 1. That will find members who have medical and pharmacy coverage from that carrier, and will not catch PBMs and TPOs. Better to use the next select statement where you use an or instead of an and. Let's look at some data. Oops. Okay. Here's my test data, and you can see the these two fields right here, you'll recall concatenated that's the member number, or the new ID we call it sometimes. And here are our sample columns: ME 018 for medical, 19 for pharmacy, 20 for dental. And here are our enrollment dates. So which members have medical enrollment in 2019? So we'll just look at some. Row 1 does, because they have a 1 here and they're enrolled. They have an active enrollment beginning in 2018, so they're enrolled in 2019. This one has a very similar situation. They have a 1 here and they're enrolled. This particular person has 2 types of coverage with this carrier, and the dates are slightly different, but they have medical coverage. And then this one down here also. So you can see those. That's pretty straightforward. Which members have pharmacy enrollment in 2019? Similar principle. You look for the ones here and you look for your enrollment dates. 1 enrollment date. Okay. Which members have medical and pharmacy in 2019? You remember, you can't look for that 1 on the same record. If it's there, that's great, but be sure to look across records. So in this case, this member does have medical and pharmacy enrollment in 2019. Yes, this is not, in this case, this isn't a PBM situation, but the medical coverage and the pharmacy coverage are handled in separate systems. So even though it comes from the same carrier, they still don't talk to each other. But you can see one for medical, one for pharmacy. And same with down here, one for pharmacy, one for medical. And in this carrier happens to be Arkansas Blue Cross Blue Shield. They know, and so the ones are on the same record. And those are the ones that have both. So as you move forward and you have to ask and answer questions about who has enrollment when, whether or not they have a claim, you can use these fields in this manner. And once you find who you need, you can go into the claims and find out if they had claims during that appropriate time. But that is a segue to the next couple of fields. So early on, we added these fields to the member data, the derived indicator fields from submitters. And this, let me go to the next one. We added these to the end of the member record, and they can be useful, but there's a caution. So we set these flags, ME018A is set to a 1 if that member had a claim, a medical claim during the enrollment period. And that can be very, very useful. Same with ME019A and 20A. This is for pharmacy and this is for dental. So we found the members' enrollment period. We found if they had claims. We looked at the claim service date to see if it was within that enrollment period, and we set the flag. However, I'm going to go back one. For example, a member could have a 2-year coverage period with claims in the 2nd year only. And if the study period you had was the 1st year, and you use that 018A field, the member would be included incorrectly using these indicators. So just be cautious. If a lot of enrollment plans are 1 year, and this doesn't really matter, but a lot of them aren't, and be careful to ensure that the claims that you pull are within the study period that you have. You can use these 6 fields, ME018, ME018A, 19, 19A, 2020A, together or separately, and it should give you a lot of options to select your study group. All right. Any questions so far? No? Let's see, at 12:40. All right. Let's talk about the latest APCD release information and data tips. So we have a new build up, brand new, brand shiny new. It has data through March 31st, 2023. The release notes are here. I always have this slide because it's very important for you to, and highly recommended for you to look at all of this information. I'm going to stop and share a different screen. Share and okay, you should be seeing the release notes, and you can get to these off of the apcd.net, or when you get this deck, you can click here. And there are lots of fun things in the release notes. I wanted to highlight a couple of them. For a very long time, we have struggled with Delta Dental because they changed systems in between 2014 and 15, and there were so many open segments, so it just looked like members were open forever, had open segments. Well, we learned, we figured out, worked with them and figured out what to do. And not this build, but next build, we will be able to close these segments and clean up the Delta Dental member data. There is a data tip here to help you manage it now if you need it. Sarah had managed all of that, and when she worked with the dental data in her study that she described earlier. There are some other data quality things here. These 2 carriers, 68985 and 69019, have significant data quality error issues. These are I can't remember. and they will not be included in any data request that comes through. The most exciting thing, I think, is where to go. Right here. The cancer registry. Cancer registry data is a very popular data source from the Arkansas APCD. And there is an entirely new layout because the layout for cancer registry is managed at the highest level by CMS, I think. And they have all new fields and new field names and a new data dictionary. We don't change any of that. We use the data as it comes. So if you are going to order cancer registry data in your next data request, do look at the new data layouts. And A, I think you'll be excited about the many new fields that are available, and B, this will be pretty easy for you. I'm hoping pretty easy for you to manage the new data elements, etc. Med Impact is a new pharmacy submitter, and they are struggling a bit with versioning and member numbers. So they will probably be in if you request a data pull, but again, I will urge you to use your release notes and your data tips and use them with caution. Same with some of these others. I don't want to read every bit of it, but I did want to point out the cancer data and the Delta Dental and the Med Impact data. Okay. Let me go back. Okay, so with every build, we build with share. That would be helpful. With every build, we create universe counts. Last time we changed the format a bit, so this will give you some overall counts by category type. We group commercial together and dental together, and etc. It's all explained in the universe count document. Let's go over there. I'm sorry to go back and forth. I'll only do this one more time. Okay. Universe counts. Okay, so you'll get to a page that looks like this. And here are the universe counts for the current build 23B and the ones from the previous build. And it'll look a little wonky here, but you'll see all of the categories of data, and it'll give you distinct member counts and distinct claim counts, that sort of thing for the different categories of data. It does include Medicare data. We have Medicare data through 2020. The 2021 data is on order. Unfortunately, Medicare data is only available for state agency use without special permission. Okay, my next slide, I'm just going to pop. I'm not going to make you dizzy by going back and forth. I've featured 3 data tips. And if you are not on our distribution list to get the monthly data tips email, do get them. But I featured the last 3 here. And this one we just talked about, this was Med Impact. Oh, let me go up. Pharmacy orphans. And these carriers this carrier struggles a bit because they're new and they have a new system. For these 2 carriers, right? Or let me back up just a minute. Med Impact provides pharmacy claims for several organizations. One of those organizations is the Arkansas Employee Benefits Division, EBD. Used to, we got the pharmacy claims directly from EBD, but now we get them from Med Impact. And there'll be a new PBM next year. So they come in 2 batches, and this is the entity code that represents each of these. And when they pull the data, they pull the member ID. They formatted the member ID a little incorrectly on the pharmacy claim. They added 2 digits, and so this data tip, when you use EBD data, tells you to truncate the last 2 bytes of the member ID to join it on the pharmacy claim, to join it with the enrollment data. Now we're going to fix this And the next time we build, this particular data tip will go away because you won't have to worry about it anymore. But we didn't want to hold this data back. It's too important. So we gave you this tip in case you needed to use it. Again, if you get to this point and you need help, reach out to us and we can help you through it. The next three files that MedImpact delivers, one is for the Arkansas State Police, one is for Arkansas State University, and I can't remember the other one. Jenny can put it in the chat. They are struggling with member IDs, and largely these data, the member data doesn't match the pharmacy claims, creating lots of orphans. Some of it does, and you can see in here there are some percentages. Like for this particular one, 99MDI1, approximately 4% of pharmacy claims don't match. This one is very problematic. 50%, 56% of pharmacy claims don't match. And then this one, 7%. We are working with the carrier to address these and fix them. But if you need to use pharmacy data, just understand that you'll see this. All right. University of Arkansas. Thank you, Jenny. The next data tip is United Healthcare, and they have, this is a new submitter as well, and they have not supplied their enrollment data yet, but we did include the pharmacy claims data so that you can at least have it for utilization. And then the last data tip that I want to highlight today, default dates and date of birth or birth year. I get asked this a lot. We have, in particular, our carrier, Caremark or CVS. It's a pharmacy benefits manager, and they have quite a few claims, or I'm sorry, member records that have a default date in them, or like a system date. It's 1901-01, 1901-0101 in their date of birth. And there's some others that we think are default or system dates. And so unfortunately, they pop up, and it looks like there is a large portion of the membership that is very old. So be aware, we haven't quite decided how we're going to approach it. If we want to if on our side, we make those blank or what, not sure yet, but be aware that this happens. Now, a lot of data users don't receive the full date of birth. They're just going to receive the birth year. And so you'll see these years in there. And I would hesitate, if you're just using birth year, I would hesitate to ignore 1950, but these others you probably could with relative safety. There's a workaround in here that could help you determine or identify a suspicious date in that case. So it is a date, ultimately it's a data quality issue. It is quite probable that CVS absorbed pharmacy data from some other entity and included it in their system and just inherited this data quality problem. But it's there nonetheless. And again, we haven't completely decided if we want to just blank those, and we don't exactly know what to do. Hate to change the data, but hate to have to manage bad data too. Welcome any suggestions. So, okay, go back. Are there any questions so far? I've been moving along well. No? All right. Okay, always look at your data dictionaries. I've updated the new cancer registry layout in there. And of course, always look at your data tips. Here are the three that we just looked at. Always look at your data tips, and don't hesitate to reach out to us. You can reach out to us at this email address. And there we are. Our next meeting is January 24th, 2024. Wow, 8 minutes to spare. Does anybody have anything to add or any other questions? Any questions for Sarah? No? Let me see here. Okay, well then I will turn my camera back on and say thank you very much. I hope you learned something. You will receive an email once this is posted. And feel free to look at this deck and reach out to us with any questions that you may have.